Hi friends, in this series of ECG Basics, today I will talk about the P wave in the ECG. First is the disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. P wave is the first positive deflection in the ECG. It represents atrial depolarization. Normal duration of the P wave is less than 0.12 second, or we can say less than 3 small square or less than 120 milliseconds. The normal P wave has smooth contour. It is monophasic in lead 2, biphasic in lead V1. It has a normal axis between 0 and 75 degree. Whenever we see the P wave, we usually see lead 2 and lead 1. It should always be upright in lead 1 and lead 2, and it should be inverted in AVR. Normal duration of the P wave is less than 0.12 seconds, as I already told, or less than 3 small square, and its amplitude is less than 2.5 mm. In the limb leads, 2.5 mm means 2.5 small squares, and it should be less than 1.5 mm in the precordial leads, that is V1. The atrial abnormalities, they are most easily seen in the inferior leads, that is lead 2, 3 and AVF, and in the lead V1, as the P waves, they are most prominent in these leads. The atrial depolarization proceeds sequentially from right to the left, with the right atrium activated before the left atrium. The right and left atrium waveforms, they summate to form the P wave. The first one third of the P wave corresponds to the right atrial activation, and the final one third corresponds to left atrial activation, and middle one third is the combination of the two. In most lead, for example in lead 2, the right and left atrial waveform, they move in the same direction. They form a monophasic P wave. However, in lead V1, the right and left atrial waveforms, they move in opposite direction, and this produces a biphasic P wave with initial positive deflection, which corresponds to the right atrial activation, and the subsequent negative deflection, which denotes the left atrial activation. The separation of the right and left atrial electrical forces in lead V1 means the abnormality affecting each individual atrial waveform can be discerned in this lead. Elsewhere, the overall shape of the P wave is used to infer the atrial abnormality. Coming to the normal P wave morphology in lead 2, the right atrial depolarization, as shown in the figure, this is the right atrial depolarization. This is brown one. It precedes the left atrium. The left atrial depolarization is shown in the blue. The combined depolarization wave, that is the P wave, this is the complete P wave, is less than 120 milliseconds. Means it should be less than 3 small square, 1, 2 and 3 small square, and its amplitude should be less than 2.5 small square, 1, 2 and 3. 2.5 small square, it should be less than. In lead V1, the morphology is typically like this. First is the positive deflection, then is the second is the negative deflection. In right atrial enlargement, the right atrial depolarization lasts longer than the normal, and its waveform, they extend to the end of the left atrial depolarization. Although the amplitude of the right atrial depolarization remains unchanged, its peak now falls on the top of the left atrial depolarization wave. So combination of these two waveforms, they produce a tall P wave that is taller than normal, that is more than 2.5 mm, although the width remains unchanged. So in right atrial enlargement, the amplitude of the P wave increases. It becomes more than 2.5 mm, that is more than 2.5 mm means more than 2.5 small squares. But its width, that is, it remains within normal range. It should be less than 3 small squares. Its amplitude increases from, and it is more than 2.5 mm means more than 2.5 small squares. This is the right atrial enlargement P wave. It is also called P pulmonale. In lead V1, the right atrial enlargement, there is again tall amplitude of the P wave, but it is more than 1.5 mm. We usually know that it is less than 1.5 mm in leads V1 for the P wave, but when it is more than 1.5 mm, then it is suggestive of right atrial enlargement. Coming to the left atrial enlargement, in lead 2, the left atrial enlargement, the depolarization lasts longer than the normal, but its amplitude remains unchanged, but therefore the height of the resultant P wave remains within normal limits, but its duration is longer than 120 milliseconds. So in left atrial enlargement, the amplitude usually less than 2.5 millivolt, but its width increases. Width of the P wave increases. It is more than 3 small square or more than 120 milliseconds, and we usually get a bifid P wave. So P wave in left atrial enlargement is called P mitral. Its amplitude is less than 2.5 mm, but its width is usually more than 120 milliseconds, or we can say more than 3 small squares. In V1, the left atrial enlargement causes widening, that is this left atrial negative deflection is more than 1 millimeter deep and more than 40 mm or 40 milliseconds. So it is more than 1 small square in both in depth and width. In biatrial enlargement, it is diagnosed when the criteria for both right and left atrial enlargement is met, and the spectrum of the P wave changes in lead 2 and V1 with the right, left and biatrial enlargement is summarized. So in right atrial enlargement and left atrial, the biatrial enlargement, there will be tall P wave with bifid P wave and more than 3 small square. The amplitude will also be high and the width will also be high both in lead 2 and V1. This common P wave abnormalities are P mitral. I already told, it is in the left atrial enlargement. It is bifid P wave, means the duration of the P wave is more than 3 small square, more than 120 milliseconds. P pulmonale means peaked P wave. It is seen in the right atrial enlargement. The amplitude is more than 2.5 mm or more than 2.5 small squares, but the width remains same. P wave inversion is seen in ectopic atrial and the junction rhythms. Variable P wave morphology is seen in the multifocal atrial tachycardias. So how do we differentiate P pulmonale from P mitral? When there is presence of tall peaked P wave in lead 2, it is a sign of right atrial enlargement. It is usually due to pulmonary hypertension. It is seen in car pulmonale from chronic respiratory diseases. So here we can see tall P waves in lead 2. The P mitral, it is a broad notched bifid P wave in lead 2. It is a sign of left atrial enlargement. It is seen in mitral stenosis. So here we can see these are the bifid P waves. The inverted P wave, it is P wave inversion in the inferior leads indicates non-sinus origin of the P wave. When the PR interval is less than 120 milliseconds, the origin is the AV junction, that is accelerated junctional rhythm. So here we can see P wave inversion is there, and when the PR interval is less than 120 milliseconds, it is suggestive of accelerated junctional rhythm. means the origin of the P wave or origin of the depolarization is from the AV junction. But when the PR interval is more than 120 milliseconds or equal to 120 milliseconds, the origin is within the atria, and we call it as ectopic atrial rhythm. P wave inversion is again there, but the PR interval is more than 120 milliseconds, so the origin is from the atria only, but it is from the ectopic site. So the variable P wave morphology, the presence of multiple P wave morphologies indicate multiple ectopic pacemaker within the atria and or AV junction. If more than equal to 3 different P wave morphologies are seen, we call it as a multifocal atrial rhythm. So here we can see this P wave is inverted, this is flattened P wave, this is tall T wave. We have different P wave morphology, more than 3 or 3 or more than 3. Then we label it as a multifocal atrial tachycardia. If multifocal atrial rhythm. If P wave morphologies are more than 3 or equal to 3 and there is tachycardia, then we call it as a multifocal atrial tachycardia. Here we can see tall P wave, small T wave, again P wave. The P wave width is increased, P wave is inverted. So here we see more than equal to 3 different P waves, and we also see the heart rate is almost more than or equal to 150 degree. It is tachycardia, multifocal atrial tachycardia, especially seen in COPD. Dr. Jonas Salk has said, our greatest responsibility is to be good ancestors. Thank you. Keep learning.